Everybody situated? Great. I didn't know we had a pointer. Oh, okay. All right, so our first case, sequencing therapies for HER2 positive metastatic breast cancer. Let's dive right in. Remember, these cases are engineered. The first one is a 58-year-old woman. She presents with a neglected breast mass for a year and low back pain of recent onset. Breast biopsy is done. It shows invasive ductal carcinoma, grade 3, ER positive, PR positive, HER2 3+ by IHC, and imaging, including a CT and a bone scan, identifies the breast mass along with suspicious axillary lymph nodes and an isolated lesion at L3 that corresponds to where she's hurting. And she has no medical issues. She has no pertinent family history. She's presented now with de novo stage 4 metastatic disease. So the first question that I will pose to our panelists is, would you offer treatment with curative intent in the setting of oligometastatic disease? And I will ask, Ruta, you're closest to me, so I'll ask you to briefly comment.
So I think it's always tempting to want to offer treatment with curative intent to these patients. I'm assuming we biopsy L3 and prove that it's consistent with the metastatic breast cancer. I think the word of caution would be that we know that these patients have some micrometastatic disease that we're probably not detecting on our imaging. So again, I think it's worth thinking about and discussing with the patient, but I think a lot of it then really comes down to what happens with her treatment course.
Mm-hmm. Cynthia?
Yes, I agree with Ruta completely. I think these patients with metastatic hormone receptor positive, HER2 positive, rarely are curable, and treatment are palliative intent. So and also based on prospective trials, removing the oligometastatic disease or the primary breast tumor has not shown or has not been clearly shown to improve survival. I think in her case, the standard would be palliative systemic therapy. I think in a case-by-case situation, we could think about treating the oligometastatic disease, I think based on the systemic treatment response.
So Christina, you have different tools in your toolbox. What would you do? Or what would you consider offering to this patient?
Well, I agree with the other panelists. I think as a radiation oncologist, especially since our technology has improved to allow us to really offer more targeted therapies with very few fractions, especially in a patient like this who's otherwise young, doesn't have significant comorbidities, high performance status, there's this desire to want to make her, stage 4 NED and try to be as aggressive as possible. And I think there's ongoing studies and some data we can discuss that has looked at this question particularly. There's the SABRE COMET study that radiation oncologists often cite, which was a prospective study looking at patients who had a heterogeneous collection of tumors. So I think about 20% of the patients were breast, but also included prostate, lung, colorectal cancer patients who had stable systemic disease, and then had up to 5 different sites of oligometastatic progression, and they were offered a randomization to standard of care, which is systemic therapy with only treating symptomatic sites of disease, versus ablative doses of radiation to those sites of oligometastatic progression, and actually showed a significant survival benefit. The difference at 5 years when they reported the longer term follow-up was 17 versus 42% survival at 5 years, which was almost a doubling. So that's very exciting. But a criticism of that study is it's pretty heterogeneous in terms of tumors. So has this been looked at in a uniquely breast population? And that's where we have some data to guide us now.
So before you take us through that breast-specific data, Komal, as another medical oncologist on our panel, how would you approach the case?
I think I agree with the panelists about trying to utilize a curative intent, especially when it comes to oligometastatic disease. And as Cynthia was pointing out, I think assessment of response to that initial therapy really helps guide. And these data that I think Christina is going to walk us through are going to be very relevant in those decision-making processes for our patients in clinic.
Great, thank you. Christina?
So we have the NRG BR002 schema. So this was presented at ASCO earlier this year. So this uniquely looked at a breast cancer population with oligometastatic disease. and they had to have controlled local regional disease and fewer than 4 sites of metastatic disease on imaging. So the stratification, and they looked at patients who had 1 versus more than 1 metastasis, receptor status, also HER2 status, and then also chemotherapy or not. And the randomization in arm 1 was basically what we typically think of as standard of care, so symptom-directed palliative therapy as needed while patients were on their standard systemic therapy, versus total ablation of all metastases, as well as the standard systemic therapy. So this would be using, in radiation, what we typically think of as stereotactic ablative radiation therapy. So high dose per fraction and very few treatments that can be delivered in a single to up to maybe 5 treatments just to the site of involved oligometastatic progression. So when they looked at the results for progression-free survival by treatment arm, even though the study was designed to show a more powerful difference, at median follow-up of 35 months, actually what was observed in the standard of care arm was slightly better. So 23 months compared to the standard of care plus ablative radiation therapy arm, where the progression-free survival was only 19.5 months. So that was not statistically significantly different. And then when they looked at overall survival also by treatment arm, similarly, not a statistically significant difference. So standard of care, 71.8% versus standard of care plus ablative radiation therapy, 68.9%. So it would appear from these data that there is no additional benefit to adding ablative radiation therapy. However, again, there's the SABRE Comet data, and then there are other studies looking at kind of different biology subtypes as well as in other disease sites to see if we can kind of better ascertain which subpopulation of patients with metastatic disease by biology may actually benefit from ablative radiation therapy in the upfront setting.
Okay, great. So let's keep the case going here. First line, she receives docetaxel, trastuzumab, and pertuzumab, and her back pain resolves, and follow-up imaging shows a response to therapy for 22 months. She unfortunately develops a recurrent back pain and a cough, and imaging documents progression in bone. There are multiple new lung nodules. Biopsy of the lung nodule shows markers that are consistent with her initial presentation, ER 75%, PR 60%, HER2 2+, and FISH amplified. So our questions for our panelists now are, what are you going to do as second-line therapy? Remember, she has lung mets, she has a cough. Does that matter? Would you do anything differently? And I'll just maybe start us off by looking at 2 of the very potent antibody drug conjugates that we have for the treatment of HER2-positive breast cancer. Remember, these are really cleverly designed, highly engineered compounds that are targeting a certain antigen on the surface of the cancer cell with an antibody. A linker then attaches a cytotoxic payload, which would be too toxic to receive free. And here you see the differences between the 2 ADCs in terms of the payload drug to antibody ratio, whether the linker is cleavable or not, and whether there's a bystander effect, which we'll come back to. So I think in this section, okay, I had asked Ruta to go through this, sorry.
So this is the data, the most updated data from the Destiny Breast 03 trial. And just to remind you, this is a randomized, open-label, multi-center study in which patients with unresectable or metastatic HER2-positive breast cancer were enrolled. These patients were previously treated with trastuzumab and a taxane in the metastatic setting or in the neoadjuvant or adjuvant setting if they recurred within 6 months of their therapy. So these patients were randomized in a 1-to-1 fashion to either TDXD or TDM1, which prior to the study, TDM1 was the standard of care. And the primary endpoint here was progression-free survival with a secondary key endpoint of overall survival. Next slide. So here you see the key secondary endpoint data that was presented at San Antonio a few months ago, last month. The overall survival was improved with TDXD. When you look at the median overall survival, it was not reached for either arm, but they showed the data at 12 months. The overall survival was 94.1% for TDXD compared to 86% for TDM1. And at 24 months, this held out. So the TDXD overall survival was 77.4% compared to 69.9%. So this was a hazard ratio of 0.64 with a p-value of 0.0037. And they also updated the primary endpoint, which was progression-free survival, and this graph is showing PFS based on blinded investigator review. So it's remarkable to see that the median progression-free survival was 28.8 months for TDXD compared to 6.8 months for TDM1. So that's a 4-time longer median progression-free survival for TDXD compared to TDM1. Here, the hazard,
I'm sorry.
The hazard ratio was 0.33 with a very significant p-value. And you can also see the superiority of the 12-month and 24-month progression-free survivals for TDXD. So I think it's pretty clear in our case which we would choose as our second-line therapy. And this is also supported by NCCN guidelines.
So in the case, anybody else do anything differently in terms of what they would choose second line? Como?
Not really. I think it's a good point that you brought up, I think, about the presence of lung metastases and how does that impact our decision, or the cough, and that impacts our decision. But at least in the data sets that we looked at from all the patients who were treated with trastuzumab deruxtecan to date, it did seem like lung metastases necessarily was not a risk factor to develop interstitial lung disease or pneumonitis, which is why we're discussing this in the first place, because that has been shown to have fatal deaths on the program. Fortunately, in Destiny-03, there were no deaths. And the prevalence of grade 1 toxicities or grade 2 toxicities were also lower, kind of suggesting maybe that if you're treating this early on to the patients, maybe you're not seeing that side effect as much. But there are other factors that one would want to think about. If you have underlying interstitial lung disease, I think that would be something one has to be wary of. There was some suggestion that perhaps a very heavily pretreated or a higher dose, certainly, but fortunately we use standard of care dosing. So I think some things to think about, but needless to say, one has to be vigilant, one has to be very careful about recognizing this and discussing that with our frontline, our nurses, our nurse practitioners that might also be interacting with the patients, telling our patients to report those symptoms so we can act on it should that happen. But I wouldn't say I would change my decision of not using TDXD just because she had lung metastases or cough.
Right. And you bring up a very good point in terms of toxicity, and as we have all of these newer exciting agents, it's always about balancing the toxicity and being able to manage the toxicity. And so that's a nice segue into, maybe Cynthia, you can take us through the toxicity profile and maybe even talk to us about what you've seen in your practice, because oftentimes when patients are treated on clinical trials, we have certain rates of toxicity, and then they get into the clinic and it's a little bit different.
Sure. Yeah, so the most common side effects from TDXD is nausea, and there are 5% grade 3 nausea that observed in the Destiny-3. Of course, in clinics, I think this is a common side effects that we see, and routinely I use the regimen that for highly emetogenic potential chemotherapies when I use TDXD, so the 3-drug regimens. Aside from nausea, it could be fatigue. All grade happens in 48% of the patients. High grade occurred in 8%, but this is very similar when compared to a treatment of physician's choice. And other side effects could be alopecia, vomiting, and neutropenia. And actually, the myelosuppressive effect was pretty good. It wasn't too severe. And in the clinic, I have very frail patients who will be able to tolerate that myelosuppressive-wise. So I think in that sense, it's gentler compared to a lot of the chemotherapies. Of course, we have seen some mild transaminitis increase and diarrhea, constipation. The next slides. So that's we'll talk about, yeah.
Before we go on, I'm just curious to know from all of you what your experience has been in terms of the alopecia, because in my practice it's been very variable. I've had some patients with pretty significant hair loss to the point that they just end up using a wig, and others that haven't really had any. Has that been your experience?
I agree, and it's hard to predict who will have more significant alopecia than others. Sometimes the more heavily pretreated, I feel like, may get a little bit more alopecia, but I have one lady who really hasn't lost very much hair, and she's been pretty heavily pretreated.
Komal, I'm sure you've used a lot.
Yeah, so I think I completely agree. You know, it's so funny that when we think about these side effects, these are some important side effects we discuss when we start a patient with a new therapy. And I always tell my patients, you can expect alopecia, and that's a big deal because with TDM1, we did not see that. So in the second line, I think this discussion is not trivial. It's very important to have with our patients about alopecia. And I almost feel like I've scared them enough, except they don't land up having so much alopecia, or majority of them don't, which is a good thing. So I think telling them about it more and then not having that necessarily so much. And I think we saw that in the data sets. Destiny-01 had a higher grade, and these were more heavily pretreated patients, perhaps more going in with some alopecia, and how we collect this data and how we report these data. And Destiny-03 had a slightly lower incidence. But yeah, in practice, I will occasionally have a patient who might have, you know, grade 2 alopecia or higher, but I would not necessarily see a whole lot of women having more than hair thinning with this drug, which has been very interesting. At the Dana-Farber, I think they're doing a clinical trial with cold caps, and they're doing that with all antibody drug conjugates, including trastuzumab deruxtecan and sacituzumab govitecan as well. It'll be interesting to see what we learn from that experience. I mean, these are Q3-week regimens, so they're longer acting. These antibody drug conjugates, I'm not sure what kind of impact we'll have with cold caps, but this is something that is being studied, and we look forward to seeing those results.
Great. Cynthia, you were going to talk to us about ILD pneumonitis.
Yes, so as Kamal and you know, and our chair has talked about, TDXD has unique side effects, interstitial lung disease, and although most of these are grade 1 and 2, when they looked at longer follow-up for the Destiny-03, 15% of the patient was found to have some degree of interstitial lung disease. So grade 3 happened in 0.8%, but nobody had grade 4 or grade 5, which was great. And this is in contrast to previous the TDM1. So as you see, the incidence for all grade interstitial lung disease for TDM1 was 3.1%. And so it is something that we need to be very vigilant about. So in clinic, this really mandates that physicians and nurses are very vigilant about symptoms of ILDs. So if a patient has newly onset cough or short of breath or fever, I would be really careful, and you would want to confirm whether it is interstitial lung disease. You could do high resolution CT scan, make sure patient has a pulse ox, looking at oxygenation, oxygen saturations, rule out whether the patient has infections, blood cultures, and in addition, pulmonary function test, and also has a low threshold, have pulmonologists involved, and pulmonary function test, arterial blood gases, and to make sure that we identify interstitial lung disease carefully. And the first thing is to interrupt the drug. And if you do have a patient has grade 1 interstitial lung disease, even with grade 1, would wait until patient completely resolve. And if a patient had a grade 2 and above, you would certainly discontinue the drug. I think our next slide shows you know, some guidelines on how to manage the trastuzumab deruxtecan-induced interstitial lung disease. So grade 1, which is, you know, you see that on the x-rays or imagings, but patient is asymptomatic. So in these patients, we also recommend to consider even starting steroids with at least 0.5 milligram per kilogram of prednisolone or prednisone dose, and gradually taper within the at least 4-week period. And we would also monitor and close follow-up these patients within a week to make sure that their symptoms are not worsening, and considering following up imagings 1 to 2 weeks after they are diagnosed. And if there's any worsening, then follow up on the higher grade management. And essentially, with higher grade, grade 2 and above, of course, you need to use higher dose of steroids. And for grade 2, the recommendation is to give 1 milligram per kilogram per day of prednisolone, or this is at least, and if symptoms worse, you can increase that to 2 milligram per kilogram, or changing to IV methylprednisolone, for example, and reconsider the workup and monitor symptoms and imaging closely. And I would always have a pulmonologist involved. So for grade 3 and 4, you would want to hospitalize the patient. These are the patients who need oxygen, and so have critical care physicians and potentially ID physician if needed, and re-imaging.
So before we move off this point of ILD, because I want to make sure that we engage with Sunil as well, it's always a waste to have a pathologist and not get his input. I always tell my patients tissue is the issue, so we've got to get Sunil's input here soon. I'm curious as to how all of you are practically managing the follow-up scan schedule, because in the trial it was every 6 weeks and insurance companies don't always pay for that. There's some suggestion that at a year you start to see lower rates, but at the same time it's a very long, or the duration or the timing can be very variable. So what are you doing in your practice? Are you following 6 weeks? Are you doing it to 9 or 12? And are you doing a short-term just CT scan of the chest, or are you doing their whole cancer restaging? Just very quickly, maybe Ruta, Cynthia, and Komal, you can.
Sure. So if there's someone I'm specifically worried about, like they have some changes on their CT scan, that, with some lung findings, I will do it at 6 weeks, which in a practical basis means like before they're coming back for their 3rd cycle of treatment. Otherwise, I'm in other patients doing it about at 9 weeks, so before they're coming back for their 4th treatment. For the most part, just doing a CT chest without contrast, although you do get a disease assessment at that time too, so it's a little tricky on what to do.
Yeah.
What are you doing, Cynthia?
So I think, for example, the patient that we just discussed, she has pulmonary nodules, has some baseline cough already. I would be more careful. I would do 6 weeks. But normally in my practice, I do every 9 weeks. And in patients who I don't really worry about progression, like she's been doing well, and otherwise I only do CT chest 9 weeks.
Yeah, so I think I agree with both Ruta and Cynthia. My practice has been this 9-week time point, which we just all made up, right? Because the trials use 6 weeks, and in practice we usually use 12 weeks. And we're like, okay, how are we going to pick up on these grade 1s, because that's what we want to do. We want to look at the scans even before patients have symptoms and look out for those ground glass opacities. So I think we found this 9-week as our way of justifying that, but that's appropriate, I think. I think, as Reshma was saying, I think the median time to develop ILD that was reported out on trials was about 142 days, but there was like a big range. Patients could have it early, patients could have it late. What was nice to look at was there was no cumulative toxicity. So once you actually pass on that 1-year time point, it wasn't that if you continued, which we do, we see these patients stay on therapy for such a long time, that you saw at least cumulative toxicity, which is nice to look at. I do get a full body disease assessment by 9 weeks, because I think most insurances do cover that, and I think it's just that one-stop shop at that time for that patient. For a patient I'm worried, or say if there was a ground glass opacity that I picked up on that 9-week time point, then at that point I would probably hold, give them the 0.5 milligram per kilogram steroid that Cynthia was walking us through, and then repeat a CT in 4 weeks to see where we are at and when can I restart or re-challenge this patient if it's a low grade that has resolved. I definitely would get pulmonary involved, but sometimes getting disease-specific help could be a little challenging in the community as well, and the academic centers too. And so at least knowing what we could do, whole therapy, starting steroids, and making sure our patients are aware, our nursing are aware of this would be a good strategy.
Great, thanks. So now let's go through a variation.
In one of the slides, they talked about checking the PK level if possible. What are you going to do about it?
So that is language actually from the protocol.
From the protocol.
Repeat the question just because she doesn't.
Oh, sorry about that. I think the question came in was that in the table for ILD management, they asked to draw a PK level. I think this was language because they had an adjudication committee, because ILD was an important side effect that they were following. The protocols were then modified to make sure that they had criteria in place about what to do and how to use that in patients who were studied on the trial. And I think this guidance came from the protocol. In practice, we're not necessarily drawing any pharmacokinetic blood draws, and so I think that doesn't apply to our standard of care practice because we now know about the PK from that. But great question and great
Thank you
pickup.
for the question. Dr. Gatz.
Just a quick follow-up question. So, in a typical FDA registration trial such as this, our scans are not PET scans, right? It is CT scan, chest, abdomen, pelvis. And so the reality is in our practice, we don't do a lot of that. We do some of that, but it's mostly PET scans. So are individuals getting PET scans plus a CT scan, or simply using the PET as your sort of, obviously we have the cuts on a PET scan are relatively, large, but are you feeling that that's adequate?
Again, a great question, Matt. I think I have been okay with PET scans. The low attenuated CT portion of the PET scan does give a sense of the ground glass opacity piece that the radiologist does comment on, and that probably prompts me to get additional imaging, and sometimes I've followed that up with even high resolution CT, not just a CT chest without contrast, because this PET is giving you that low attenuated CT to begin with. So I've been comfortable doing that, but it's a great point because that's not how it was studied on the clinical trials.
Elise?
Hi, good morning. I have a little different, similar but a little different twist, which is the pulmonologist. My husband's a pulmonologist. So when they look for problems with interstitial lung disease, they do not do PET scans, as was just pointed out, because you need HR cuts. But more importantly, pulmonary follows these people with PFTs, which are cheap and easy. So, if I have someone that I'm at all suspicious, usually you're hand-holding with the pulmonologist, but if you are not, getting PFTs is really the first and easy, cheap way to start monitoring. In our institution, they'll do high-res cuts at the base of the lung because that's where you'll first start seeing the fibrosis, rather than doing it throughout. So there are different protocols that can be utilized. I guess my question back to the panel, though, is how often do you really see this? In your clinical practice, how often are we seeing this? Because I think this discussion sometimes terrorizes people and they don't want to use the drug because they think, oh my gosh, 15% in the clinical trial. But back to the question, is this real world medicine?
Yeah, I think in my own practice, I'm a breast oncologist, so I see breast cancer patients. I've given a lot of TDXDs. I think so far I've seen 2 patients with that. Yeah, I haven't seen a lot actually.
Yeah, I've seen a couple cases also. I think, the differential workup is really important. We are still in the midst of the pandemic, and COVID pneumonia can present with some findings that are overlapping, but there's a test for COVID. But differential diagnosis is really important. I had another patient who had prior radiation, and there were some radiation changes in the lung that we're kind of overcalled as suspicious for possible pneumonitis. So I think that it's important to have it on the radar. So I'm going to move us along.
Reshma, could I ask one final
Sure.
question?
Sure.
Over here.
Oh, sorry, Neil.
No problem. So this dovetails off of this last question. One of the things that I wonder about as we shift towards looking at regular CT scans or whatever methodology to screen for ILD is the incidence or impact on the RDI or relative dose intensity of TDXD, right? And so I'm wondering if the panel has a sense of, in this initial time period where we don't have that data, how is this practice impacting our delivery of the drug? How often are you holding or delaying or even modifying the schedule for TDXD based on your screening for ILD?
So I think, as fortunately Cynthia was pointing out, while this is an important side effect and we are very vigilant about it and we should remain vigilant about it because what it could do, we're not seeing so often that we're dealing with ILD with patients on TDXD, and that's been the experience in clinic as well. And so thankfully it's not like we're holding a whole lot of TDXD in patients because we're seeing a whole lot of this. But when we do, I think, grade 1 is when we catch them by doing these scans early, hopefully, and are able to intervene early, treat them with steroids, and re-challenge them. And that's been my experience.
And I have a lot of conversations with radiologists. Whenever there's something abnormal on CT, I call them, and a lot of times actually they can tell me, okay, this doesn't really look like ILD at all. So I would just keep going.
So, as I mentioned when we started, these cases are engineered, and we've taken the liberty of changing this case a little bit to bring up the discussion of HER2 low. So let's vary the case a bit. Say the patient initially presented with an ER positive HER2 2+ FISH not amplified breast cancer, and then developed a recurrence in bone. And importantly, as we're all excited about a lot of these, about TDXD and the data in HER2 low, it's important to recognize that we still have a standard algorithm for exhausting endocrine therapy, CDK4/6 inhibitors, in combination with other targeted therapies as well, like alpelisib in the setting of a PIK3CA mutation. And say she had gone through all of this and one line of chemo with capecitabine, and upon symptomatic progression in bone and liver, the liver biopsy now is HER2 0. So before I again engage our medical oncologists in the treatment decision part, I want to get the input of Sunil in talking us through HER2 low.
Sure. So traditionally, we have been trying to differentiate HER2 into 3 different grades. To put it simply, is it a flat ground? Is there grass growing on it? Are there shrubs? And are there trees? And those are the kind of distinctions that we are trying to do. And the only thing that was important was, are there trees or not? And that is 3+ or not 3+. That's what everybody was asked to do. And so whether there were shrubs or grass growing, and whether it's ornamental grass that is a little taller or shorter, we really didn't care. Now, as the things have developed, we are trying to differentiate and being much more stringent about differentiating the shrubs from the grass. And that's where all of this talk about HER2 low is. The criteria are still the same. It's just that people are being asked to use them more stringently to try to differentiate different levels of expression. And that is all the story about HER2 low. That is, there is some level of expression, and we need to differentiate what that sum is, but it is not the 3+ level. And then depending upon your pre-analytic and the post-analytic methods, you may see some degree of variation between the biopsy and the excision, because if you remember, the biopsy goes into formalin within 1/10 of a second, while the excision may be sitting for a couple of hours before it goes into fixatives and things like that. And then of course there's natural variation between different sites of tumor. And it has to be remembered that the patients were enrolled based on expression of primary or metastatic lesions. So whatever tissue they got for the trial, that was tested. And these include all sorts: primary tumors, lymph node metastasis, distant metastasis in different organs. Any and every tissue apart from cytology was used to include or test for the patients for HER2 expression. So there's a wide variation, and there can be quite significant differences in these low levels of expression depending on the tissue, depending on the time of biopsy, depending on prior therapies. Almost 20 years ago, Craig Jordan's group showed that HER2 expression increased following endocrine therapy. And then now we are seeing that too. So there may be an impact of therapy that comes along. So there are a lot of these changes that we are talking about. And then one category that to remember is what is called ultra low, which is basically, it's not flat ground, there's something growing on it. Okay. So again, we don't know whether that is going to be important in terms of TDXD, but those kind of trials are still going on as to how low is low expression. So it could be simple in a couple of years as 0, some expression, and a lot of expression. That is, and if that happens, all this conversation of HER2 low will kind of fade out. But in the meantime, we have to struggle between differentiating the different levels of expression, particularly between 0 and 1, because we have an artificial cutoff of 10% to differentiate the 0 from 1. Back to you. So here's a couple of expression. Levels, as you can see, there's very faint expression levels here, and these low levels of expression are sufficient for the patient to be treated with these novel agents. So we don't need the old definition of complete, strong, intense membrane positivity. What we are now talking about is perceptible membranous staining, even partial staining of the cell membrane in 10% or more of the cells. So as you can see, whenever we talk about percentages, there can be a wide variation depending on which area of tissue that you're looking at. So there are a lot of variations, but we'll hopefully sort these things out in the near future.
So Ruta, before you take us through the bystander effect, just a quick vote for the case as presented with Sunil's comments. Would you treat with TDXD in that situation?
I would. I would definitely consider it. I think, you know, exactly what Sunil said, this patient that we're talking about would have been eligible for the trial because she did have HER2 low expression in her primary tumor. And there, we know there is some heterogeneity of HER2 expression from the primary to the metastatic site. So I would consider it.
I agree.
I would agree as
Okay. All right, Ruta, do you want to take us through these slides?
Sure. So one of the key features of TDXD is this bystander effect, and I think Reshma pointed to it on the slide that was comparing the two antibody drug conjugates. The bystander effect is really the potential for TDXD to overcome the HER2 heterogeneity and have activity in tumors with variable levels of HER2 expression. And so the figure on this slide kind of walks you through that. If we look at number one, we can see that this antibody drug conjugate localizes to the tumor and binds to the target receptor antigen on the tumor cell surface, here which is the HER2. Then the second step is that the receptor antigen and the ADC are internalized, and the ADC is then enzymatically degraded with lysosomes, and this releases the cytotoxic drug, which binds to the intracellular target. And the fifth step is the ADC then mediates death of the antigen-expressing cancer cell. Because the membrane permeable drug, it can be released and taken up by the neighboring cells. And so this is really the bystander effect, which is the death of the neighboring cells. And we think this is one of the key features of TDXD. And that brings us to DESTINY-Breast04, which we've been talking about for this second patient case here. And I just want to go through the data with you. So this was in HER2 low advanced breast cancer. These patients had received 1 to 2 prior lines of chemotherapy. And as in our case, if they were hormone receptor positive, they had to be considered endocrine refractory. They were randomized in a 2-to-1 fashion to DDXD versus treatment of physician's choice, which could have included other chemotherapies, eribulin, capecitabine, gemcitabine, nab-paclitaxel, and paclitaxel. There were 557 patients, and I just want to point out that 89% of these patients were hormone receptor positive. So the overall response rate in this study was 52 compared to 15% for TDXD versus treatment of physician's choice. On the right of the slide, you can see the PFS for the hormone receptor positive patients and all patients, showing superiority for TDXD. And at the bottom, you can see the overall survival in the hormone receptor positive and all patients, again showing superiority for TDXD.
Oh, sorry.
No, go ahead.
Okay. All right. So let's kind of take it back to the original patient that we had presented that was HER2 positive. Elise, did you have a question?
Did she get hormone therapy?
Yes.
Yes, our patient did.
She.
We call her refractory.
Correct, and I think that's a great point. The question was, did she get hormonal therapy and did we call her endocrine refractory? Again, as excited as we are about the data with TDXD in HER2 low disease for an ER positive HER2 low patient, that standard algorithm is still to exhaust endocrine therapy and the targeted therapies that we have in that setting. So thank you for, again, making that point. So let's switch back again to our original patient who was clearly HER2 positive the whole time. And in the first line setting, she got the Cleopatra regimen of taxane HP. And second line, she got TDXD based on the DB03 data that we just went through. She responded for about a year. And at the time of progression, her systemic disease remained controlled, but she had 2 new lesions in the brain that were found incidentally when she took a fall, hit her head, had some brain imaging, and she's completely asymptomatic. So the question I'll pose to our team here is, would you change the systemic therapy? What are the local treatment options? Would you hold off on local therapy entirely? And as we go through that, maybe we can first review, Cynthia, you could take us through the ASCO guideline update, especially highlighting, what to do in this situation where there's systemic disease control and progression, isolated progression in the CNS.
Sure. Because of the HER2 CLIMB data, I think ASCO provided updates on the guidelines. But essentially, first, for patients whose systemic disease is not progressing, and at the time of brain metastasis was progressing but treated locally, and systemic therapy does not need to be changed. So we do not change anti-HER2 drugs in that setting. And for patients whose systemic disease is progressing at the time of brain metastasis diagnosis or progression, we should change their systemic HER2 target therapy according to the algorithm for the treatment of HER2 positive metastatic breast cancer. Of course, treat the brain met. And the HER2 CLIMB regimen, which is trastuzumab in combination with tucatinib and capecitabine, may be offered for patients with HER2 positive metastatic breast cancer who have brain mets but without symptoms from the brain metastasis or no mass effect, and whose disease have progressed from at least one HER2-directed therapy for metastatic disease. If these drugs are used, because they have shown CNS activities, local therapy may be delayed, which I think is more kind of in line with our patient. This could be an option. And the fourth is in the guideline, the HER2 CLIMB regimen of tucatinib plus capecitabine plus trastuzumab may be offered to patients with stable metastasis after their local therapy or intracranial disease progression. So this is, we know that TDXD is our second line option for systemic disease progression, but these patients, if they have stable brain metastasis or have progressing brain metastasis, HER2 CLIMB regimen is another option.
That's a great segue.
Sure. So just going over the HER2 CLIMB, this is actually a randomized phase 2 trial that established the HER2 CLIMB regimen, the trastuzumab plus tucatinib plus capecitabine, and this was randomized to placebo plus trastuzumab and capecitabine. And then, so these enrolled patients who had HER2 positive metastatic breast cancer, who had prior treatment from trastuzumab, pertuzumab, and T-DM1. But this trial is unique that they allowed patients with previous brain metastasis that were treated, but also patients with brain metastasis that has not been treated, but not needing any immediate local therapy. And also patient who had prior treatment for their brain metastasis now is progressing, but does not need immediate surgical local therapy. So these are, additional criteria. So this is the overall population at the median follow-up of 14 months, looking at PFS on the left and the overall survival on the right side. You can see a 2.2-month difference improvement by adding tucatinib in the PFS, and overall survival advantage of 4.5 months in the overall population. So with a longer follow-up, the overall survival benefit continues to be there. At 29.6-month follow-up, there was a 5.5 months advantage by adding the tucatinib. And looking at specifically patient with brain metastasis, so this is one of the secondary analysis. So on the left side is the progression-free survival and overall survival. You can certainly see the advantage with the addition of tucatinib, very similar to the overall population. And there is looking at patients with active brain metastasis, you can see the improvement in overall survival from 20% to 47%. And also these are looking at intracranial responses. And on the right side is a CNS PFS improvement from 4.1 months to 9.5 months, which is fairly dramatic. And the overall survival advantage almost double that. So that kind of established the regimen.
Great, thank you for taking us through those data. So in this situation, again, we'll get back to the question about what you would do. I think, Cynthia, you had mentioned what you would do. Ruta and Komal, if you can comment briefly, and then we are getting to the end of the session, so I want to make sure that we get to the progress we've made in local therapy as well.
So I think this is definitely a situation now where we need to think in a more multidisciplinary way with the two new brain metastases. So I would involve our neurosurgical colleagues as well as our radiation oncology colleagues to all work together to determine what the next best treatment would be for this patient.
I would agree. I think, we get comfort from the HER2 CLIMB data set that if a patient could be approached with the systemic therapy, in this case, given there's no edema and there are smaller size lesions which would have matched her eligibility criteria for HER2 CLIMB, that's an appropriate regimen. But I think I would always involve my neurosurgery and my radiation oncology colleagues to make sure we're all on the same page and following this patient well.
So Cynthia, I'll turn it over to you. Or sorry, Christina, I'll turn it over to you.
Well, the HER2 CLIMB data are obviously very exciting because we know that with longer term survivors with metastatic HER2 positive disease, a decent percentage of our patients will progress with CNS disease. And anytime you're talking with a patient with stage 4 disease, factoring in their performance status, quality of life, as well as progressing, increasing their survival. So when we're thinking of how do we present options for a patient with systemic disease, and we factor in their performance status, the NCCN guidelines here, list a number of different options. So, one is whole brain radiation therapy, and we try to stay away from that now, just given the side effects. Significant fatigue, there's some degree of cognitive deficit over time, even though we do have some additional tools. So, memantine was shown in a randomized study to improve cognitive outcomes in the long term. And then also, even when we're doing whole brain radiation, using IMRT with hippocampal sparing is another option to spare the hippocampi, which are centers of memory, to try to improve patients' long-term cognitive outcomes. But then even still, with better imaging precision in a patient such as this who only has 2 lesions, they don't have particular symptoms, there's less edema, even stereotactic radiosurgery is also an option. And even still, I should add, I guess, for patients who have larger lesions, anytime there's significant edema, midline shift, herniation, obviously our neurosurgical colleagues are important there for debulking, because in that setting, radiation would actually likely cause more edema. So just explaining some of, I guess, more the details of radiation options. So stereotactic radiosurgery is generally preferred over whole brain radiation for patients who present with limited CNS disease. We factor in both the size of the lesion, any edema, as well as the number. So when we're treating stereotactically, usually we try to go for high doses in very few fractions, so anywhere from 15 to 24 gray, and that's been shown in different dose escalation studies to be effective in terms of local control. And then as we deal with either more numerous or larger lesions, we sometimes have to fractionate, so sometimes 3 to 5 treatments to try to minimize the consequent edema. And then for patients who may have a surgical resection for a larger symptomatic lesion, we'll sometimes also offer additional stereotactic radiosurgery to the cavity to try to increase local control. And then again, whole brain radiation was our standard for many years. Doses tend to be the typical course of 10 to 15 fractions, and that can be done with either hippocampal sparing or memantine to try to decrease some of the long-term cognitive effects. However, we're also seeing for patients who may have limited life expectancy, worse KPS, that we can even do whole brain radiation in as few as 5 treatments if those patients have disseminated CNS disease and require whole brain radiation. So on the next slide, I guess that animation didn't work as I'd hoped, but there's a subsequent slide that should have some
sorry.
images
That
of
was my
treatment
fault.
planning. No worries. So, depending on how acute some of these patients present, there's also a factor in terms of time delay, just in terms of initiating treatment. So, the upper left just shows the immobilization mask that we often have to coach our patients for during treatment planning, because now at some of our treatment platforms we can treat with, millimeter accuracy, but these masks do take about 45 minutes to make, and then the patients would wear that during the subsequent treatment. So in the lower left, we have just kind of a dose cloud showing what whole brain radiation would look like, whereas just to the right of that, you see what hippocampal sparing IMRT would look like, where we intentionally carve out and create cool spots in the radiation dose cloud to minimize dose to the hippocampus. And then in the center, these are just different options in terms of stereotactic radiosurgery, where there we can hone in and just treat the involved lesion. And there's many different treatment platforms, whether CyberKnife, like in the upper right, which kind of uses a robotic arm on our linear accelerator to precisely target the lesion with very tight margins. There's also MR-Linac as a platform, and even a traditional linear accelerator can do this. But just in terms of workflow, even though our desire is to offer patients stereotactic treatment because it decreases the fatigue and the cognitive deficits and minimizes the edema, technically speaking, these usually require a lot more treatment days just in terms of planning. Because we usually have to get a high-resolution MRI for fusion that requires significant physics involvement and then quality assurance. So these are treatments that usually, it's harder to initiate those within a week, let's say. It can take sometimes 2 weeks even just to initiate treatment, and then they would be delivered in a single to up to 5 fractions. And then a note on surveillance. Just because especially what was exciting about HER2 Climb is, a lot of these patients had active CNS disease, and it often comes up after a patient has had some form of local therapy. There can be fluctuations in the treatment cavity if we're treating postoperatively, or even the size of lesions. Is this real progression or is it pseudo-progression? So this is just an example of how there can be variation for an intact lesion. So, on the left we see what it started with in terms of a rim-enhancing lesion. Following up, this patient was treated with fractionated stereotactic radiation. Following up 2 months after radiation, we see some involution of the size of the lesion, but then at 4 months post-treatment, there's actually enlargement. And so this would be a time point where it's helpful to have radiation oncology involved, because we're able to do fusions with the surveillance MRIs and our treatment plans to actually see if the area of increased enhancement is inside or outside of our dose cloud, to better know if this could be pseudo-progression, which is better treated with observation and steroids, versus if this is true progression and we should consider restaging the patient and assessing whether they need a change in therapy altogether. And in this case, you see at 6 months, we again see some decrease, again confirming that this was pseudo-progression. So close interval follow-up was appropriate here.
So as we close out the session, I'll just take us through this approach to therapy for HER2 positive disease, and then we have a moment and we have some questions from our virtual attendees that I'd like to have addressed as well. So notice the slide says post-ESMO 2021. That's when the DB03 data was presented and was really our line in the sand for when we started doing things differently. What hasn't changed is that first line data with the Cleopatra regimen of taxane, trastuzumab, and pertuzumab remains our standard. As we discussed, the majority of patients in the second line based on the DB03 data will be appropriate to treat with TDXD, but for those patients with active CNS disease, especially CNS and systemic progression, we went through really exciting data with the tucatinib regimen. And then, there are unanswered questions like, we still have TDM1, and what will the activity of TDM1 be after TDXD? I think that remains to be clarified. There are some issues with understanding how to optimally sequence as we get into the third line and beyond. And unfortunately, we didn't have a chance to go through some of the even newer agents that are available, like margetuximab and in combination with chemo based on the SOPHIA trial. We have an approval for neratinib and capecitabine based on the NALA regimen for patients after 2 lines of therapy in the metastatic setting. And of course, there's also still older data with trastuzumab and the TKI lapatinib that actually showed a survival benefit. So the good thing is our patients are living longer and they have the opportunity to be exposed to many of the therapies, and understanding how to optimally sequence them, identifying biomarkers of resistance and mechanisms of resistance will be important as we go forward. With that, I would like to just spend a moment addressing some of these questions through the virtual chat. The first one is a pathology question. A little complicated, as is life, right? Because when we have those patients in our clinic with the actual path reports, they're never as clean and easy as we've discussed. A patient who had initially HER2 1+ in an axillary lymph node core biopsy, but the breast biopsy was triple negative, and this is after neoadjuvant therapy. She has 7 out of 10 nodes with HER2 positive disease confirmed by FISH. So it was 1+ initially, and there's some sense that post-operatively it's HER2 positive. So the person is asking about doing FISH testing on the specimen that was called 1+. Maybe, Sunil, you could talk to us about how common it is for a HER2 1+ tumor to actually be FISH positive.
So, again, a great situation here. We know from old data that even some of the zeros can be positive. Okay, so positive by FISH, I mean. The percentage of it is so small that typically we do not do any testing for the zeros and the 1 for FISH. And that FISH testing has been essentially limited to the 2+. The agreement between IHC and FISH tends to be quite high when you're looking at 3+ cases, but even you will have 3+ cases that are FISH negative or FISH positive cases that are not 3+ positivity. Whenever we are looking at different modalities, that is one where we are looking at protein by IHC and DNA amplification by FISH, you're going to see different results based on the platform for testing. So just think of it as headquarters giving the orders and the workers actually doing the work. And that's really what we're talking about. The DNA amplification is what's happening at the headquarters. There are multiple processes by which protein expression is regulated, and therefore that particular order may not get transmitted and converted into protein at the cell surface. So 1+, we believe it's around 5% of the cases could be FISH positive. And then with the 2+, it depends around 20-25%, depending on how frequently people call something 2+, and then more than 90% when it's 3+, that is FISH is positive. So I hope that answers the question.
I think it did. Here's one more question. In a metastatic breast cancer patient that's ER positive, HER2 2+, or okay, it actually says HER2 positive, with liver lesions at presentation, if someone has a great response and is then NED for more than 6 years after treatment with trastuzumab and pertuzumab alone, would you consider giving a treatment break to see what would happen? I think we all have a few of these patients in our practice and we really struggle. It's a good problem to have because it means our therapies are so effective, but on a practical level, when the patient has to keep coming in every 3 weeks for so long, it becomes tough. What do you guys do?
I can start off. I think, yeah, no, it's a good problem to have, as you said, and I think we do know that a small proportion of these patients potentially, might I use the word cured in the metastatic setting. I mean, with Cleopatra, the complete response rate was about 5%. I wonder if this is now going to be seen more often, given that we've seen in the DB03 data set, the complete response rate was 20%. So 1 in 5 patients had a complete response. And it's potentially possible that the durability would be longer and maybe they are not going to have this disease, act up again. However, it is a data-free zone. It makes you and the patient both nervous about, rocking a boat that's sailing so smoothly. And so I think it's an individual patient-physician decision-making process. I think we both have to, be on the same page, understand the data-free zone here. There are trials that are now being developed to address this question, and hopefully we will not have to do this, so heterogeneously in our practices with our patients. It's called the Stop HER2 trial, and that's a trial initiative within the Translational Breast Cancer Consortium that hopefully will help address this question better. But otherwise, I think I've just dealt with it on an individual-to-individual patient basis.
Quick
Me
final
too.
comments?
Yeah, this is kind of in my own practice. Sometimes actually patients would elect to change to trastuzumab alone, and just because they may have had diarrhea, side effects, skin rashes, and to improve their quality of life, and have not really discontinued trastuzumab. But I think regardless, I would just monitor, making sure if I do discontinue.
And I agree with everything Komal and Cynthia said. I think the other thing we can also think about with these patients, if they're continuing on single-agent trastuzumab or the combination dual antibody, is thinking about giving them the subcutaneous formulations to make their lives a little bit easier in terms of coming in every 3 weeks.
Yeah, that's a great point.
Quicker office visits or treatment visits, and no need to access their ports or get
Great.
IVs.
Well, this has been a wonderful session. Thank you all to our panelists.